Good afternoon, everyone, and welcome to another episode of Office Hours. I'm your host, Stuart Newsom, and joining me today is Jason Adams, the president of Ni2 Health. Welcome aboard, Jason. How you doing today?
Great, Stuart. How are you today, sir?
I'm doing fantastic. I'm so happy to have you here, especially for the topic that we're going to be covering. It's titled "Optimize EMR Workflow for Post Go Live Mastery in RCM." And there's a lot packed in there. So we're going to unpack that, of course, over the last several minutes here. EMR conversions are really no cakewalk. Anybody that's been involved in those know that the best laid plans never exactly go as planned. You got to plan accordingly. And there are many factors that are considered that most of those who go through these conversions will consider things like patient care workflow, physician satisfaction and adoption, clinical documentation, as well as the anticipation on leveraging. Uh, there seems to be an excitement, so to speak. So it's understandably there's some nervous optimism for this fresh start, so to speak. We're going to start new. But so often the RCM component is left out of that equation. It doesn't seem to be a factor or even considered. So today we're going to look at why this is often the case and advise on how to remedy this oversight. So Jason, what are the top pitfalls when it comes to forgetting about RCM that organizations make during an EMR conversion?
Well, I think that's a very long list, but I think a good way to think about it is if I were to rank them in a brainstorming session of the top five, because organizations are focused on patient care, patient safety, speed of access, speed of documentation, making sure their patients get through. There isn't a lot of disruption to schedules, workflow, and the like during a conversion. However, if I were to say, let's pick a top five during a conversion that are impacted in need for an assessment post conversion, it's really around, let's start at the beginning with payer and plan code mapping within the system and those tables.
Hmm.
Another key piece would be their information workflow around hard stops with registration. And I can get into that detail. And then charge reconciliation would be another one. Claim rejections and denials would be a fourth one if I'm counting properly.
Hmm.
And
Good.
then really payment validation, number five. So
Gotcha.
picking top five, because I could go on to give you a top 20 and we'll only talk about three of them in a half hour.
Oh, I'm sure. And you could break, yeah, like you said, you could break these down in detail. So let's start doing that. All these issues really make sense to kind of to me to consider that. So it's hard to understand why they're overlooked. And starting with that first one on breaking these down, uh, just talk a little bit about payer and plan code tables and mapping. We all know that's important. Mapping is a big word in EMR conversions to make sure everything's mapped over, but particularly payer plans and code tables. Why is that significant?
Well, in legacy EMRs, they don't update things as frequently, and often it's a copy paste.
Mhm.
Oftentimes, organizations simply copy what they had in their legacy system, move it over into their new EMR, and then the pains and blemishes from the legacy system are simply duplicated in the new EMR as opposed to going through a detailed mapping of what are all of the new plan codes. Plan codes change all the time. Plan benefit design relative to employers, whether they're self funded, non self funded, and the like change constantly every year as employers shop for new plans based on the escalating cost of health insurance.
Mhm.
So that impacts everything. That if you had Blue Cross mapped to plan code A120 and now it should be plan code B630 and it's not mapped properly, and the registration reps are selecting Blue Cross in that plan code that they thought was the right plan code and it's being billed out that way, it's going to get rejected and denied. And it's just delaying your payment for other work on the back end.
Right. That makes total sense. Absolute sense. So moving on to the second one that you mentioned, which is critical workflow. Why would clinical workflow information and hard stops, as you will, be ignored?
Go lives are hectic. And to leverage all the hard stops in the registration workflow during a go live is very cumbersome. Most organizations turn their hard stops off for go live and rarely remember to turn them back on. Because again, during a go live, you want the patient throughput to be a focus along with patient safety, but hard stops by way of required critical data elements such as date of birth, social, contact number, verification of insurance, etc., enforcing new insurance verification during every intake process, plus during a new EMR go live, that's a challenge. However, these processes, they're best practice workflows. They take time. Many organizations turn them off
Mhm.
during call it a week, 2 week period to improve intake, when in reality it's harming the organization by way of incomplete information and then delays in billing and increase in stage one denials due to incorrect data. It's really a needed focus to review what are those critical data element fields that should be a hard stop, ensuring that they're on and ensuring that there isn't a bypass mode from your front end registration staff. And then
Right.
during a post go live EM optimization review, leaders should look at what fields within the EMR are recommended by your EMR to be hard stops and then verify those hard stops are actually in place.
Yeah, make sure those are customizable and that are enforced. And you hit on a key point there. Don't enable those certain people to turn those off. Have that more as an administrative right, so to speak. So, can you explain how hospitals can get a grip on their charge reconciliation during the conversion? Moving on to that third factor.
I would say this is the largest area of opportunity post go live within the CDM and charging practices. Converting to a new EMR and ensuring that all charges flow properly from the point of care and make it all the way to the claim is a very daunting task. Even the best pre live risk mitigation plans, testing fail, unfortunately. Post go live charge reconciliation is a must. If there's one thing to focus on first beyond anything else I've already articulated, it would be charge reconciliation.
Mhm.
You got to have baseline reports. What was your revenue by service code and service area prior to go live based on volume? And then what is it post go live? Reviewing where you were before go live and comparing department line item reports is a key to success. Many organizations embark upon that journey with an external partner because it is such a significant lift. You have staff members that have their day job. How do they do 2 and 3 jobs when the primary focus is patient care?
Right.
So being guided down a methodical path with the support of some technology is critical. Technology alone is not just going to get you there in and of itself. Leveraging that technology, leveraging algorithms, leveraging AI affords organizations the ability to work by exception. Compare your baseline to compare your current run rate. The key is that the internal teams really don't have the bandwidth, and you need either a specially assigned work group, you need a trusted partner, you need people that understand healthcare revenue in order to track and trend department to department post go live, and then to work to identify where the deltas are and fix the root cause. A line by line, department by department, claim by claim review should be done within 6 months post go live, and then have some type of measurement and monitoring mechanism so you're reviewing your revenue on a very consistent basis.
Mhm. Yeah, that's smart. That's real smart. And then the fourth one that you mentioned, which was claims rejections and denial review, and this is something near and dear to my heart. And I know that in the past, from what I've noticed and observed, is most people would want to keep the old system for a certain period of time, keep those claims and rejections and denials in that system, and then start new, start fresh, like I had said earlier, in a new system. And there's obviously some dangers to that, and I can see the advantages to that. But What are the advantages you see for reviewing claims rejections and denials in that RCM conversion to a new EHR?
Well, I think what I was referencing before was really about what are your net new rejections and denials in your new EMR, meaning as you're billing claims, usually out of a new billing scrubber, new EMR, there will be new rejections and denials that you may have fixed in your legacy system that are now popping up in your new EMR environment, new billing system. So it's about really understanding how those reports are compiled and having accountability within the organization to review them to get to the root cause, that to then track and trend those, because you're not going to eliminate them, but you should be able to reduce them month over month. And
Right.
when it comes to denial data, 9 out of 10 facilities see an increase in denials post go live. The organizations that really separate themselves from others are those who focus on the data to get to that root cause. So again, in the legacy system, you may not have a denial for A, B, or C because you've been on it for 15 years and you've been able to figure it out and fix the root cause or put band-aids in place.
Hmm.
The key from a post go live perspective is to look at what has occurred post go live, how long has it been happening, what's the volume of impact, but getting to the department specific root cause and fixing those things so you don't have a forward flow denial and rejection problem.
Right. Because if you're going to start fresh, you don't want to inherit the problems you had before. That's for sure. So this review would certainly help in that area of claim validation, which is the and payment validation, which is the last point here. But what opportunities are there with EMR functionality to help with this?
So a lot of the new EMRs, not to mention names, have mechanisms to load payer contracts, to load estimated reimbursement to be able to see if you're getting paid properly. This, again, of course, takes skill and expertise and someone dedicated to maintaining those tables. But I encourage organizations to leverage the technology. They're paying for it. Use the functionality within that EMR to be able to see where you're getting incorrect payments. Not that they're getting incorrect payments on purpose from the payer source, but stuff happens. And it's a matter of both sides understanding healthcare economics and understanding payer reimbursement and really understanding how claims are paid and what is considered the allowable. Are you getting your allowable from that payer source? The unfortunate thing is, in today's day and age, many organizations have these processes buried within their contractual allowance, and they don't have the best posting process to then identify the underpayments or staff at the right sequence in the line of the claim to then determine that the claim was actually underpaid because it's just being buried in contractuals. And to think that you're going to find an underpayment in hundreds and hundreds of thousands of dollars of contractuals is unrealistic,
Right.
is the best way that I'll say it. So, from a top item, from my view, it's making sure that you have the ability, the technology, and the mechanism to review your paid claims to ensure you're being paid properly.
Wow, that makes sense as well. So these is all of these very certainly are some valuable insights to indeed for that fresh start that I mentioned earlier with the RCM component. Very important to consider it. You made some excellent points here in an EMR conversion. I'd now like to turn this over to any questions from the audience, and there is the first question here is there a time frame to review improvements or an assessment of how effective the RCM workflow is after conversion?
I would say after the dust settles between 6 and 9 months, and definitely no more than 12 months post go live. 6 months, you're out of the pain and suffering.
Mhm.
9 months, you're beyond pain and suffering, and you're probably in a post go live steady state. And what was fixed due to post go live identification has been fixed internally. And I recommend around that mark bringing in a trusted external partner to be able to give a good diagnostic of where everything sits and where your opportunities reside.
That's awesome. That's awesome. So, and I don't, let's see, we have a question that came in here. From a marketing perspective, what do we offer to help when facilities do not utilize their EMR properly and realize they go live was not as successful as they expected? That's a good question.
We as an organization help all sized organizations review their EMR post go live. We actually offer free assessments to be able to diagnose and map out a plan for all clients to improve their EMR post go live. So Ni2 is in this space and does this every day, helping organizations optimize their EMR.
Oh, excellent. Excellent. Well, I don't see any other questions. We'll give a few more seconds for some questions to come in. I just want to go ahead and let everybody know that next week, office hours, we will be live at HIMSS, the HIMSS conference. So we're going to attempt to perform in office hours from HIMSS. We're going to be talking about intelligent payer mapping with Akar Sethi. So really encourage everyone to join us. Any questions? Any further questions, Jason? So I really appreciate you coming on today. I know you're extremely busy, but anytime that we can grab you to share your knowledge, we know it's always an advantage, not just for me, but also for our audience as well. So really appreciate your time.
Great. Thank you very much. Hope you have a great day.
All right. Thank you, everyone. Thanks for joining us today.